welcome back to the Seamless Connection. Today, I'm thrilled to be speaking with Deborah Campbell, VP of Clinical Strategy and Transformation for the Kentucky Hospital Association and the leader of Kentucky's IPASS initiative, along with Dr. Christopher Landrigan, Chief of General Pediatrics at Boston Children's and one of the founders of IPASS. Welcome both to the show.
Thank you.
Thanks very much, Meena.
It's an honor to have you, and I'm looking forward to learning about your work to reduce medical errors and the role technology plays in improving transitions of care. But first, before we dive in, I'd love to learn a little bit more about both of your healthcare journeys and what's brought you to where you are today and what's brought you to IPASS and your individual careers. Deborah, if we could start with you, would you share a little bit with us in terms of what got you into healthcare in the first place? And I know you have a clinical background yourself and of course have now transitioned to bringing that clinical experience to a broader audience.
Thank you, Meena. Sure. Well, I was a candy striper in high school, so that's my first exposure to hospitals. They don't even have those anymore. But I started out in pre-med, actually. And when I had a child, I thought that might be a little bit more commitment to time away from home than I wanted. So I went to nursing school and found that was actually a better fit for me. I liked being with the patients all the time in the hospital for all of my shifts, and I really enjoyed that. So I started out as a pediatric nurse. Went to pediatric ICU and became a director and did that for many years, probably most of my career. And through that role, which has many hats, I got into quality and infection prevention, and I was a clinical nurse specialist for a while in pediatric cardiology, and then found my way here to the Hospital Association, where I was attracted to this because I could have a role in helping people across a broader area. So not just my hospital, but the state. So it's been a great run, and that's a long story because I've been doing this for a while. So.
And we'll definitely get more into that. And Dr. Landrigan, how about you? And I'm going to start with a quick question. Sure. Because we're talking about a completely different state from where I think you're located, but maybe you'll correct me if I'm wrong, from Boston Children's all the way to Kentucky. So I'd love to understand that relationship.
Sure. Well. So my dad was a pediatrician and public health researcher, and my mom was in public health as well. So I definitely had influences from early in life that pushed me in this direction. And I was sort of a reluctant beginner, I suppose, in the healthcare journey. I wasn't really sure that I wanted to go to medical school or walk down that road. But, at some point, I suppose in my late teens and college years began to shift my tune a little bit. And so walked in this direction. And like Deb, I think as I looked at various fields in healthcare, was drawn to the pediatric side of the table. And so I ended up pursuing residency there and then doing a fellowship after that in pediatric hospital medicine as well as health services research. And, really for about 25 years now or so, have been thinking about the ways in which the design of our healthcare systems affects the clinical care that we provide on a daily basis and the safety of care writ large. So that's really been a lot of my focus throughout my career is trying to figure out, what goes wrong in our systems and what can we do to try to make things a little bit better.
And what got you interested around the specific concepts? I know you both have done a lot of work with handoffs, transitions of care, and especially in the acute care setting, obviously pediatric focus, but I'm sure the lessons you learned can be applied more broadly to other patient populations. What got you specifically focused on those areas?
Yeah, so for me, I began my training at a time just when hospitalist models were beginning and was something that I was really drawn to. And it was sort of this idea that you've got a hospital-based physician who's really thinking about the big picture of healthcare and what can we do to try to organize and coordinate care a little bit better. And then not too long after that, the Institute of Medicine's initial report to Err is Human came out, which for the first time at a national level, I think really painted this picture of how often things go wrong in our healthcare systems and how many systemic problems underlie those sorts of things. And so I started out just trying to understand how do we systematically measure rates of medical errors and harm and patient safety as a way of beginning to get our hands around that so that we can hopefully tackle it. And then spent a number of years looking at resident work hours, which was something that had certainly affected me when I was in my own training, and trying to think through reduction in work hours and what impact that might have on patient safety. And that really led into this area that became IPASS, of thinking about teamwork and transitions of care, because as we shortened hours, we were seeing more frequent transitions of care between those doctors in training. And those transitions, it turned out, were really problematic, and there was a lot that we could do to try to fix that.
And can you give us a brief description of iPass?
Yeah, so iPass began about 15 or 16 years ago, initially as a pilot research project at my institution, where again we saw that these transitions of care were really variable, even from one resident physician to the next, never mind sort of from one team to the next. And so we just started thinking about what could we do to try to structure those a little bit better and get rid of some of the unwarranted variability that we thought was likely driving errors in care. And so we got a small grant from Crico, our malpractice carrier here in Boston, and did a project where we tried to put together what we called a bundle of interventions for handoffs. Which consisted of just some training, some standardized training for residents, as well as some changes to the verbal handoff process and changes to the written handoff process, working with our IT folks to build something into the electronic health record. And when we did that in really short order, those simple three interventions, were associated with something like a 30 or 40% reduction in medical errors on those units. That ended up getting published in JAMA and then serving as the preliminary results really for a larger federally funded study where we kind of did the same thing at a broader scale with the input of medical educators and researchers and hospitalists and others who all came together and helped us think through how can we build something from this nugget that is a little bit more sustainable and that's really going to work across different types of hospitals and health systems. And that's really what became iPass. This combination both of a structure. iPass is a mnemonic that stands for the things that we would like to hand off at change of shift or when a patient changes locations. But iPass also refers to that broader process of how do you actually manage that change and make it real. We don't want this just to be 5 letters that are hanging on a poster on the wall that nobody pays attention to. We want this to really change the way that people communicate and speak with one another daily.
And it's been around for now about 10 years. What are some of the biggest impacts you've seen from the implementation of iPass, whether it's in the hospital setting or broadly with your peers in terms of how they approach the handoff process, the sign out process?
Well, our initial data, that study that I talked about, the federally funded study, was 9 pediatric hospitals across the U.S. and Canada, and we really rigorously measured the frequency with which patients were experiencing medical errors or harms as a consequence of those medical errors after we put the program in place, and saw a 30% reduction in patient injuries as a consequence of errors after iPass went live. That was published.
Can I pause you right there? Do you have specific anecdotes about scenarios where iPass can come in and maybe a before and after of like, this is how it would have been done before, but this is what we've actually seen with kind of specific case examples as you may share?
In a general sense, I can. So, we saw that when we looked at the types of errors that were reduced by implementing iPass, a lot of them had to do with diagnosis and communication about kind of patient status and what was going on with a particular individual. There were also medication problems and other sorts of things, in a sense, really broad, but I would say that those were kind of probably the dominant categories that were there. So once we put iPass in place, those types of things were just happening less often. It was less often the case that somebody forgot to follow up on the results of a lab test, or there was you forgot to mention that this patient had a history of diabetes when you were kind of signing that patient out, or that you and the surgeon had been working all day long on what we were going to do if that belly pain got worse. That information wasn't passed off to the person at night, and they kind of ended up in a situation where they're trying to recreate the wheel from scratch.
No, that's perfect, because we see this a lot. I mean, we focus on specialty services, not necessarily for the pediatric population, but it's exactly those same situations where there's a culture that's pending, or there's a surgical decision that's pending, or there, a discharge, and it's the work has been done, and all of a sudden it disappears.
Right, exactly.
Right. Yeah. Well, that's fantastic. And so with that report that you had, and you saw that the effects of it, and that was with those 9 initial hospitals, what was the reception in kind of the broader audience? I know, Deb, you work with the hospital association. Was there acceptance? Was there pushback? Was there fear? Because one of the scariest things in healthcare is medical malpractice lawsuit, right? So if you're asking hospitals, and on one hand, I could see how maybe administrations could be nervous about admitting they have a problem in the first place to then put in a solution to that problem. I'm curious if you run into that, or if that was an issue as you got the iPass initiative up and running.
It's a great question. I think we have come a long way around that. There was a time when we weren't allowed to use the word harm, patient harm, in any of our meetings, but we've come past that. And actually, on the contrary, we facilitate patient safety cultures, both the ARC and those types of surveys for our hospitals, and give them the reports back and ask them, how can we help you with what you saw in those reports? And what we heard for a period of time before I engaged with Chris and others at iPass was that they were saying we need help because our communication is showing up as a problem. And did they want anyone else to know that? No. So to your point, that wasn't something they wanted publicized. However, they wanted help, and they were asking us for solutions, which is how we ran across iPass as a possible solution for the hospitals.
And in the modern day version of iPass, it's obviously, I'm sure, gone through many iterations from when you first started, Dr. Landrigan. What does it look like today? So if a brand new hospital comes to you or a new health system comes to you and says, hey, listen, we've been trying it our way. There's still room for improvement. What can you do to help?
So we started evolving about 10 years or so from a program that really was a research focused thing, primarily concentrated in pediatrics, to something that really was much broader. I think to your point, Meena, that these are not unique issues in pediatrics. We started recognizing that as well, and began to make that transition by doing some dissemination implementation studies where we looked at what happened if you tried to apply this type of a solution in an adult hospital, in obstetrics, in surgery, in neurology, in community hospitals versus the big academic medical centers. And pretty much we're finding across the board as we studied this in different places that the effects were the same. I mean, if you sort of boil it all down, essentially any place that we studied this, we were seeing 30 to 50% reductions in miscommunications, medical errors, adverse events. But the challenge was it was enough of a lift for hospitals to really do this at scale across multiple specialties that it just was not happening organically. And we had tried to put a lot of our materials out online and to kind of encourage hospitals through various mechanisms to spread the program. But I think it was just too difficult, honestly, for them to do that on their own. So about 8 years ago or so, we formed the iPass Institute, which is an entity that was formed really to try to help with that problem. And through the Institute, we built a series of digital tools to try to make the adoption easier for hospitals, and kind of paired that with consulting or mentor and implementation model that we already had in place. And that has proven to be really effective and has allowed us to scale this in a way that we just weren't able to do before.
And is that something that they just integrate into the EMR? So it's maybe a document template that they've kind of got at the end as
So yes and no. I mean, I would say that the primary process at this point is that if a hospital or system is interested in doing something like this, that they reach out to us, and we'll often start with a whole series of conversations on where they are right now, a little bit of a needs assessment, trying to think through what do they need to really transform their communication practices and safety writ large. And often we have been able to dovetail into things like movements to make hospitals into high reliability organizations. There's sort of a very nice synergy, I think, between what we do and those types of efforts, or sort of other types of efforts to, I think, just improve the reliability and safety of care. But I would say there are certainly some digital tools that are involved in this, but more than that, it's really a behavior change process and kind of a culture change process in institutions to get them to just think differently about communication. And so, we provide some software now that helps with the training and makes it really easy to kind of scale training of this in a very adult learning centric way across an entire organization rapidly. We have quality improvement tools and other sorts of things that help hospitals go live with this as well. And we do have a whole series of templates and other things that we've built to try to help them with the build of EMR-based tools within their own systems. But I would say that in many respects, the more important part is this change in behavior and change in culture around communications, where we're intensively training and we're reinforcing, we're working with institutions to identify their quality champions and other folks who can help to sort of enhance this and amplify it at a local level. And that process takes some time. So we'll engage with institutions and we'll typically be involved for 2 or 3 years or more. To get this process up and running and then to sustain it.
And then when you think about how physicians practice today, no one has enough time. Right. And no one has enough time with the patients themselves, much less to have a proper handoff or sign-off conversation with their peers heading into the next shift. What are the challenges beyond time? And how do you address that very key kind of rate limiting step of not having enough time before they're rushing off to the next thing as people go into that process? Because you nailed it on the head. It's change management and it's making sure it sticks. But if it's not a sustainable workflow that fits into all the 50 zillion other things they have to do that day, how long will they keep doing it once you leave, right? So I'm very curious how you get it to stick and how you get them to slot another thing into their negative time bank each day.
From very early on, even in the early research phase of this, we recognized that the time management issue was going to be really critical. That if this took longer than what people were doing at baseline, they weren't going to do it. And so we studied that really carefully. We did what's called time motion analyses, where we had research assistants following residents and nurses later on in real time and really tracking moment by moment how they were spending their time, and did this add actually to the burden of their work days, and demonstrated that for the physicians, it did not. And for the nurses, if anything, it actually went the other way, where once we provided this process for them, it's tended to streamline handoffs to the point that in some institutions that we worked with now, we're seeing reductions not only in the duration of the nurse handoff, but actually decreases in nurse overtime. Because it turns out that an overly protracted handoff is one of the major reasons that nurses stay over on their shifts if they can't do that process efficiently. So this actually helps with workflow, it turns out, which I think runs a little bit counter to the way that most people would think about it. And I think the other piece of that, just to keep in mind, is that if you have an efficient handoff up front at the beginning of a shift, the frequency with which you're going to have to then delve back into the medical record or sort of look up information over the course of that subsequent shift is down as well. So there's sort of downstream efficiencies as well as that kind of upfront, I think, benefit.
No, that's such a great point in terms of you don't think about the downstream impacts, positive and negative, but in this case, very much positive. Yeah. It sounds like in terms of there are ROI impacts to this whole change management process beyond just the immediate, which is great. Let's talk about the pediatric population for a second. I know you said this can be used beyond that, and it started to, but you started it specifically for the pediatric population. Why is that, beyond you being a pediatrician, of course? But are there specific challenges or unique challenges to the pediatric population from a sign-off, handoff perspective that aren't there with others, or is it just that you happen to be that happens to be your field?
It's more the latter. I think there are unique challenges with any population, right? I mean, as we've adapted this process to work with obstetrics or surgery or pediatrics or ICU nurses or whoever, we're respiratory therapists, anybody we're working with, there are always unique aspects to what content is passed off during those handoffs, and kind of getting that content right is a big part of our initial, I think, build with any given institution, trying to figure out how to do this in the way that's right for them. But fundamentally, I think the process is not that different across pediatrics versus surgery versus others, which is why this works. And I think what we're really hoping to achieve, and I think particularly what we're hoping to achieve with Deb's group in Kentucky, is the idea that this could become a universal language for the way that these transitions occur, so that any clinician, regardless of what hospital they're in, what specialty they're from, sort of what their discipline is going to talk about patients in the same way when they're being passed from one setting to the next or from one shift to the next, which I think, has this synergistic potential effect on the safety of care, and will be able to achieve things that I think we haven't even been able to achieve as yet.
That's fantastic. And Deb, to Dr. Landrigan's point about working specifically with the Kentucky Hospital Association, what are the goals here with IPASS in terms of, is it to get it to every single hospital in Kentucky? Are there specific use cases that you're targeting that you want to make sure that you address up front? What would you consider a win?
Well, I will say, first of all, that Chris kind of stole my theme because every time I talk to the hospitals, one of the things that I say to them is, what I would love to see, kind of my stretch goal, is that every hospital in Kentucky do this. So that, because we do a lot of transferring, we're big rural areas and populations. And so we have a lot of patients that go from the rural hospitals and in the mountains and into bigger hospitals, into systems. We actually have within systems a lot of transferring. And so, my ultimate vision for this is that we're all speaking the same language, so that when patients go from Appalachia, into Louisville or into Lexington, Kentucky, to the big university center, that we're all using this. And further, actually, the thing that is so different about this, if you don't mind me going back to something Chris said earlier, is the way that this is done is different than any other initiative that I've been exposed to. And that is that there is a lot of, I should go so far as to say, kind of hand-holding to help people through the process of setting up committees, finding the champions, how the observations are done, how often, what you do with them, how you give the feedback. So that it's very spelled out, it's very organized, there's a timeline. That helps people stay on task and helps them get it done. Maybe the more important thing is about sustainment. and that there's a process that the IPASS Institute folks help the hospital embed so that this becomes just the way things are done, and they can follow through with that. They can do the kind of backside monitoring to make sure that this stays in place and that it doesn't fall off and it's not flavor of the month and all those things that hospitals hate and quality improvement people hate. It's what really attracted me to this. This isn't, we're going to have Chris and his folks come and give a webinar and then everybody go home and do this. That's just not realistic, especially hospitals who have who are under resourced.
Yeah, no, and that's such a great point you bring up that is underlying enough, not just in Kentucky but elsewhere in terms of being rural populations and experiencing a lot of transfer. So it's not just the inner shift handoffs, but it's the transfer from a community hospital to an academic medical center type situation where there is a lot that is lost, potentially, right, if it's not done properly, and if there's not enough time to go back and read through the transfer documents and the EMR, the CDA, and all of that. So completely understand how that use case, and Dr. Landrigan and Deb, but for both of you, what made Kentucky, kind of the Kentucky Hospital Association in particular, step forward and take this challenge on? I haven't seen other hospital associations do that yet. So I'm very curious, Deb, if it was just the fact that you are just facing the reality of so much of your population is impacted by this, or if there was more to it that made Kentucky a natural fit here.
I think a little bit more to it in that we have I think we are unique in the relationships that we have with our hospitals. There's a lot of strong personal relationships. I think Chris would attest to that. And people tell us what they want. And we're very conscious of their issues and their problems. And so I was looking for something. And, to be completely transparent, I was just asking to do this for X number of hospitals initially, because obviously it's not free. And so, but I had some leadership here who, when I said this can be transformative, I mean, hate to use a word out of my title, but it's the truth. I feel like this can transform the way people in hospitals talk to each other and the way patients are cared for in a safer way. And so, I would like to provide basically kind of like scholarships or grants for this. And they were like, well, how would we pick? And I was like, right. So we decided we would offer it to everyone. And then, my goal of seeing everybody do it is kind of lives with me all the time now. But I don't know that Kentucky's different. I think we do have a bit of a different relationship with a lot of our hospitals. And I know we are not the only ones that have under-resourced hospitals, but we have a lot of them. And they really rely on us to bring them things to help them do a better job of caring for their patients. And I believe that's probably why we are where we are today. And Chris may have other thoughts about that. I don't know.
Yeah, I guess the only thing that I would add, my answer is maybe a little simpler, is they have Deb, the Kentucky Hospital Association. I mean, seriously, I think, it's hard to underemphasize the importance of a really strong champion and leader who I think can see the value of something like this. And I think, from my perspective, it's been remarkable, Deb, what you've been able to do and to sort of advance this up the chain of the hospital association and get people on board with this.
No, it's fantastic. And then circling back to how IPASS actually works today versus what it started off as, right? And correct me if I'm wrong, both of you, because as the experts on this, but IPASS standing for illness severity, patient summary, action list, situational awareness and contingency planning, and then the last one, synthesis of the information. There's been so many developments with technology to address some or all or pieces of all of this in the last decade. So I'm curious, how have things changed from what you started as, and has it gotten better with the new technology that's come into place since then, with remote monitoring, an increase in virtual care? I don't know if that makes it better or worse. Changes in EHRs and integrations between those. So I'm very curious as to your opinions, both of you, in terms of the role technology can play in preventing medical errors and the role it is playing, as you see through your initiative, and how it's impacting maybe those key areas or others that kind of are relevant here.
Well, maybe just as a starting point, I mean, I don't think we would ever have been able to scale the program without the technological advances that have happened. Honestly, our original model back in the research studies, just to take training as an example, is we had this workshop model. We had a lot of medical educators who were involved in our original study group, and they were really invested in concepts of adult learning theory and trying to make sure that you're not just speaking at someone, but you're engaging with them. You're really getting them to kind of practice something before they're doing it, and then finding ways to reinforce that as time went by. And a lot of the initial intervention was built around that, from sort of live simulations to workshops to a lot of the reinforcement that we did on hospital units as we got the program up and running. That type of a model worked great when we were working with one residency program at a time, or one nursing unit at a time, but is completely impractical when you are getting to the point that you're trying to deal with 5,000 or 10,000 clinicians across a medium-sized hospital or system. And you just can't, there's no way to sort of go around from group to group to group to group over the course of a year or two and adequately train them and then expect that the project's going to stick. It just takes much too long to kind of launch something like this across the system. And so, we began to think through what were the technological solutions to try to solve that training dilemma. But the last thing that we wanted, I think, particularly with the input of some of our medical education friends, is we did not want a PowerPoint slide that people were going to click through on their own and kind of get to the end and sort of do this 5-question quiz and declare that they were competent. We knew that was really not going to be effective education or an effective way to launch a process like this. And so we spent a lot of time actually working with some pretty high-tech companies that do these 3D immersive simulations, where our training now, you'll on the first page say, I'm an ICU nurse, and then you get dropped into this ICU nursing module. You'll learn a little bit about the basics of IPAS that is somewhat didactic, but then the heart of the training is you're looking at videos, evaluating good and bad handoffs, and then more importantly, you get presented with a patient in your chosen field. Things change over the course of that shift. And at the end of the shift, after you've been taught how to do it with the didactic, you are asked to practice doing both a written and then a verbal IPAS handoff by recording yourself speaking into the computer. After you've sort of done that recording, the recording will play back to you. With the playback will come kind of an answer key for what should have been on that handoff. And you'll do a little bit of a self-assessment of saying, did I include these things? Did I not include these things? So with that type of technology, we have something that's very engaging. It adheres to principles of adult learning theory, and that people are actually interacting with this thing. It's not just sort of speaking at them, if that makes sense. They have a chance to practice doing things in a safe environment. They get a score in sort of a very low stakes type of an environment, and off they go. And that whole process takes, 45 minutes, as opposed to our original workshop model, which took maybe 3 hours. And so much more efficient, really effective. It allows us to kind of adapt this for, we now have a library of 30 cases or so across specialties and disciplines, and has really helped, I think, to be able to do this at a scale that we just couldn't do it originally.
And on the other hand, with more technology comes more interactions between people that can go awry. So I think this becomes even more important, not less.
Yeah. Yeah. Thanks, Deb. I agree with that. I mean, at the heart of this, right? So the technology can help, but at its heart, we're trying to change the way that people speak to people, and the technology can really only do so much with that, I think, which is why I think that high touch process that Deb talked about is so important, of our going in and working directly with the hospitals and, clinicians and thinking through what are their existing processes and how do we walk them through taking those hopefully to a better place.
And does this answer apply whether it's a resource constrained hospital or not? And I want to be sensitive to Deb's point, which is there are a lot of hospitals that their heart's in the right place, but the budget might not be, right? So how do you put trainings in place or put these new processes in place, or these new resources in place when the budget might not necessarily stretch to everything that you would do elsewhere?
I mean, Deb can speak to this too, but again, from my perspective, that's one of the remarkable things that's happened in Kentucky, is that the hospital association is supporting the bill for this, right? They are paying for the hospitals to implement the program. And as an institute, we have been working to try to replicate that model across other states and through other avenues wherever we can, because that financial barrier is real for institutions. I think it's, we can't do this work without some support, I think, for the people and the time that's required to make all this happen. And we completely understand that there are lots of low-resourced hospitals that can't do it on their own. But that said, there's a lot of money in healthcare. And I think this is the type of thing where we've been able to demonstrate that the return on investment is enormous. Just in terms of reduction in adverse events and the costs associated with those sorts of things, reductions in overtime, at least from a couple of studies now, and at the most extreme cases, reductions in malpractice claims. We've projected now. Independently done study, but I was wasn't part of the IPAS Institute, but I was involved in it personally, where we found that 27% of all malpractice costs could potentially be averted by using something like this, just because miscommunications are so prevalent in malpractice claims. It's such a big part of particularly the biggest claims that are out there.
27%. Do you know what that equates to from a dollar value?
$1 billion a year.
Oh,
So that pays for a lot, right? If you can sort of avoid those costs.
That pays for a lot. And Deb, to Dr. Landrigan's point, how are you able to help? How is the Kentucky Hospital Association able to help with this in terms of, and if you're able to share it, I know a lot of the audience would be very curious as to rough costs even of what does this cost to, if someone else wants to think about doing this, what do they need to be able to support? And are there grants? Are there other resources available that can help you do this? Or is it something that the hospital associations just prioritize as, hey, this is our initiative for the year and this is what we're going after?
The Hospital Association, without the aid of our Hospital Rate Improvement Program, which is the partnership between our Department of Medicaid Services, CMS, and the Hospital Association, which is an ACR program to help the hospitals realize more reimbursement up to average commercial rate. That program has provided dollars back for the Hospital Association's administration of the program with those entities. And those dollars are earmarked for quality. So the question for the Hospital Association was, how do we best allocate those dollars that are coming to us based on this program? And so this is one of the things we're doing with those dollars. And we feel like that it is cross-cutting. So it's not just helping the metrics that we're looking at in our HRIP program, which is hospital rate improvement. The metrics that we're looking at, of course, are infections and readmissions and other things. But our take on this is that IPAS crosses all of those different harm areas in so many ways, and that we can improve kind of everything if we're communicating better. And so that's why we chose this for a big portion of those dollars.
No, it's fantastic. And to the point about ROI, what are you seeing in Kentucky? And I don't know if the program's been around long enough to run the data that way, but can you speak to what you've seen either anecdotally or with hard numbers on, for example, the equivalent of what are you able to cut for medical malpractice or transfers or transfer issues or anything that you've been able to see specific to Kentucky?
I think it's too early. Chris, let me know. But I think we're just
we're only months in at this point. So
we really have two hospital systems that are now up and doing the training and have a go live date. But so we're early. But I will say we're planning for that. So we've already thought about that and what are the things we're going to be looking at down the road. So you'll have to talk to us again.
I was going to say, how much time? I will do the follow-up. How much time do you need to get your wish list? And so we've spent a lot of time talking about IPAS, and obviously its phenomenal impacts on patient care and medical error issues. Are there other initiatives that you both are working on that you're just as excited about, or that you have high hopes for in terms of having future potential impacts?
Chris, you're nodding.
Yeah, so a lot of my work is in this space in one way or another, although there are different arms to it as time has gone by. I mean, maybe the biggest additional one to mention is the patient and family centered IPAS program, which is more at a formative stage right now. We're not trying to really roll that out. But the idea here was we started recognizing, 8 years ago or so, that we were having physicians speaking to physicians using this IPAS structure and nurses speaking to nurses using this IPAS structure in my institution, but they weren't speaking to each other, and nobody was involving the patients or families in those types of conversations. And we thought that there was potentially additional benefit if we could do that. And so we started designing the patient and family-centered IPAS program, was this idea of let's take IPAS structures and language and begin embedding them into family-centered rounds. And see what that does to patient safety and patient experience and so forth. And a lot of that work's been funded by PCORI. And we have found there now in a couple of studies that have followed sort of a similar pattern as the original iPass handoff program. We started, sort of with a smaller multi-center study and then went up to a 21 center study after that. Really similar benefits. I think even in institutions that were already using this for handoffs, we're seeing another, for example, 38% reduction in harmful medical errors in a study that was published in the British Medical Journal back in 2019. So, I'm very excited about that, and trying to essentially go through the same exercise with that program as time goes by. Let's figure out ways to scale this. Let's grow this over time, and let's try to get that integrated into systems that are beginning to walk down this road as well.
Does any of this apply into the ambulatory setting? Because I know, again, coming at it from a specialty perspective, there's a lot that gets lost between that consult referral from the PCP to the specialist, right? And I could see, and again, it's not the acute care setting. I don't know if the impacts on medical error rates would be quite the same, but there definitely would be clinical impacts and improvements in care, and potentially delays in care. With that PCP to specialist communication. I don't know if that's an area of focus for either of you, but I'm curious to see what you think.
That's really the cutting edge of where our research is now. We have a new grant from the Agency for Healthcare Research and Quality that's really looking at exactly that question. This idea of, can you integrate some of these strategies into the ambulatory space as well, and specifically, what would that do to diagnostic safety, rates of diagnostic errors, as patients move between locations, and particularly complex patients as they move between various specialists in the inpatient and the outpatient setting and so forth.
Yeah. I was looking at some study the other day, and this is granted for VA patients, but their patient file is about 1,800 pages. So imagine trying to pre-chart on someone, getting a referral on someone with that, and you're like, what is exactly the key aspects that I need to focus on, which would be an enormous job for anyone. But yeah. I guess the last question I would have, because I can't not bring up AI these days with everything and everyone is talking about, but a lot of health systems and EMR and technology platforms are very excited about bringing in AI to help reduce the workflow and work burden on clinicians, doctors and nurses. One of the key areas that people talk about, and that seems to be getting more traction even in the hospital setting, given security concerns, is automatic transcribing of notes and working to help with capturing that. How much of that can be used to help simplify or streamline the handoff process if they're able to use more technology and less physical time documenting what needs to go through? Do you think there's opportunity there? Are you more concerned on, what could come that is overlooked today?
I certainly think there's an opportunity there. We're early, right? I mean, we're very early in the world of AI, and need to get to a point that it's reliable and is not going to, sort of the issue of things like hallucinations in AI, I think, terrify clinicians, that false information actually might get put into there. But, all that being said, if we could develop a good process where AI can generate an initial version, at least of the written handoff document, and that then somebody really is very carefully reviewing that and making sure that it doesn't have mistakes in it or false information, then I do think that potentially could save clinicians time down the road. Now, from my perspective, the written handoff tool is a small piece of the overall process. So it can help. I don't think it's ever going to replace, I think, the types of things that we're trying to do in terms of having behavior change and changes to the verbal processes that clinicians use. But I do think there's a potential time saving there once those tools mature enough.
No, that makes sense. And Deb, from your perspective, is it an opportunity or a risk or still TBD from a broader hospital association?
I think some of the concerns that we've heard folks express as some of the companies have come in to talk to them is the fact that we thought we had these wonderful systems that would allow us to do nurse assessments and kind of copy them forward. And of course, we've had major issues with that because people have copied inaccurate information forward, and just the human nature of reading something to review it for error. It doesn't work well. We know that we don't see it, right? We read what we think we should be reading. And so I think that I've heard probably more concern about how these would work and what the pitfalls are. And people want to see it in action and they want someone else to do it first. Chris and I both heard that through this process. They want, you try it and you let us know how that works for you. So I think there's a lot of hesitation. And we've really focused at the Hospital Association here in Kentucky, we focused more on building the human I call it the quality army, because we just haven't had that because of the under-resourced hospitals, which I keep saying. But so we've been doing things like having partnering with the National Association of Healthcare Quality to support certified professionals in healthcare quality. We've done like 450 in that
Mhm.
partnership. So because we're feeling like if you have those people who understand this, they can be part of the people that are vetting these things. So we've kind of focused on that end so far, but of course we're approached quite often, and it's fascinating. And so I think there is opportunity. I would agree with Chris. It's just I feel a little
A little
cautious about it.
cautious. Yeah, me too.
Yeah, no, I think that would be what we're hearing broadly throughout kind of the industry. There's a scope for opportunity, but it needs to be judiciously managed. So I know we're coming up on time. Thank you both for spending a small part of your day with me. I thoroughly enjoyed learning more about both IPASS and the work you both are doing, both here in Kentucky as well as Dr. Landrigan more broadly, on pushing forward communication and workflow as well as behavioral changes, just as important to get preventable medical errors down. And I am very impressed that you got people to admit to them in the first place and that you're able to make it better. I actually very much look forward to having a follow-up conversation once you've gotten these hospitals launched, Deb, here in Kentucky, and maybe in a year or so, kind of seeing how far you've gotten down that road and what the early results are. Because it sounds like the long-term results that Dr. Landrigan's seen, it sounds like there's big numbers to be had. So I'm looking forward to it.
Excited about it. Thank you.
Thanks so much.